morning, everybody, and I thank AIOS for this opportunity. I'm going to speak on non-surgical management of a very common disease, of a very common strabismus that we have in our part of the country and our part of the world, that is intermittent divergent squint or intermittent exotropia. It's not moving. The slides are not moving. So the natural history of intermittent exotropia goes from exophoria to intermittent exotropia to constant exotropia. And it usually progresses with the age because of decreased tonic convergence, decreased accommodative convergence, and with age, there is increase in orbital separation, and there is a peculiar hemiretinal suppression which occurs in these patients, which causes the patients not to appreciate the diplopia and then have refixation fusion movements. So that is why it actually progresses. And if we can stall the disease somewhere in the exophoria or intermittent exotropia phase, we can avoid surgery. And all of us who have dealt with these patients and have operated on these patients know the pitfalls. There can be exodrift or recurrence. The younger the age of surgery, the higher the recurrence. It is very difficult to pinpoint and get correct angles. You tend to slightly overcorrect to avoid this exodrift, but if you have overcorrect more, then you can end up with microtropia and amblyopia. So you have often get undercorrection and end up with a challenging second surgery. So who are the ideal candidates where we actually think of non-surgical management? They are the young children, the smaller deviation, less than 20 prisms, and patients with good control. Coming to control, good control can be measured objectively by stereoacuity, better for the distance because that goes first and later for near, or you can have the Newcastle score where we have where we have home control and clinic control. Good control is when they don't notice squint 50% of the time. In clinic, good control is when there is immediate realignment after a dissociation, or they can realign with a blink. So how does non-surgical management help? It helps to reinforce fusional potential, to teach the control of deviation, to eradicate suppression, and to create an optimal sensory condition before you plan surgery. The modalities include correction of refractive error, overcorrecting minus, part-time occlusion, prisms, orthoptics, and botulinum. So if there is an uncorrected refractive error, the visual blur destabilizes fusion in intermittent exotropias. Whereas a clear retinal image improves sensory and motor fusion and also helps us in giving a correct angle of deviation. In myopes and astigmats, we correct fully. In hyperopia, we usually undercorrect to the extent of 1.5 to 3 diopters. If we undercorrect more than 3 diopter, it actually relaxes accommodation, and in higher hyperopes, you should not undercorrect too much because again it will cause a blur and it will defeat the purpose. Overcorrecting minus glasses had been fashionable a few years back. It is usually preferred in preschool children because older children may not accept the over minus glasses. It works by stimulating accommodative convergence and thereby improves control. How much do we overcorrect? Anywhere up to 1 to 3 diopters in increments of 0.5. We observe the control over the deviation, and it is very important to call them for follow-up. The first follow-up should be in 3 weeks to 4 weeks, and then thereafter in 3 months, and you assess the improvement in the NCS score. However, there are cons of over-minusing. They can actually develop myopia. In this day and age of myopia pandemic, we wouldn't want to do that. They can also develop near esotropia or phoria and asthenopia. Part-time occlusion works by eliminating suppression, so it helps the patient to appreciate diplopia and thus have motor fusion. It improves stereopsis and it might decrease the angle of deviation, and it can help in postponing the surgery. We can do monoocular if you have a dominant eye, which it is usually true in these cases, or you can do alternate patching part-time in these patients. There are many studies in favor of these. Akbari et al., Al-Kahmouz et al. Observed good control of intermittent exotropia with part-time patching. However, the PD group did not find that. Orthoptics exercise has been tried for these patients. They work by anti-suppression training, correcting abnormal retinal correspondence, improving fusion, and usually it improves the convergence and achieves binocular single vision. Box strings improves convergence. Lifesaver cards improves free space fusion. The VTS4 software are used for improving vergence facility, mainly convergence. Aperture rule and Bernaloscope are all for improving the convergence facility. So which patients will show the best response to orthoptic therapy? They are the basic exotropes or the ones which has convergence insufficiency. They improve when you improve the convergence. And the ideal protocol that we follow in our institution is 1 to 2 times a week, 60 minutes each time, 10 sessions of in-office therapy, and we add that with home reinforcement 15 to 30 minutes per day for 5 days in a week, and this continues for about 6 months, and we call them for a follow-up and see whether they need more. Prism therapies, again, base-in prisms or relieving prism enhance bifoveal fixation by bringing the image out of the suppression scotoma. You can have overcorrecting prisms again to induce diplopia and stimulate fusional convergence. We have base-out prisms which can improve control sometimes in intermittent exotropia. Botulinum toxin can be given anywhere between 2.5 to 5 international units into the muscle belly, which is actually a little far from the insertion or from the limbus, and you can have adverse effects as globe perforation. So to summarize, we know that surgical intervention in intermittent exotropia at very young age has poor sensory and motor outcomes, and postoperative drift is common regardless of age. Non-surgical options give us a scope to postpone surgery, sometimes avoid surgery, and provide an optimal sensory milieu for surgical success. Thank you.